Dr. Nageswaran is a professor in the Department of Pediatrics here at Wake Forest University School of Medicine. She is also a pediatric palliative care physician and provides medical care for children with serious illnesses. Dr. Nageswaran has created multiple innovative models for care, including 3 community care coordination programs, and also she has created and leads the first pediatric palliative care program called Pediatric Enhanced Care Program here at Brenner Children's Hospital. Dr. Nageswaran has decades of experience in conducting research on improving healthcare delivery for children who have medical complexity and are having serious illnesses. Her research is funded by NIH, HSRA, and many prestigious foundations and internal grants. She has recently received $4.4 million award from PCORI to study the effectiveness of health model of care for medically fragile children in primary care pediatric practices. We are very happy to welcome you, Dr. Nageswaran, and we are very excited to hear your talk.
Thank you, Arizu. Thanks for this invitation as well. I think Latrice contacted me a few months ago, inviting me for this to do this presentation, and I told her that I have no experience in AI. But the reason Dr. Gurkin invited me was because one of the projects that we did as part of a pilot CTSI pilot grant was actually we received supplemental funding from the then Wake Forest Bioinformatics Center, and it was extremely helpful to have that supplemental funding and to be able to do that pilot grant, and which then led to the PCORI award that we currently have. So as I had this opportunity to do the presentation, I thought it would be really good for me to introduce this population, the children with medical complexity, to the AI audience, and just so that you're familiar with some of the challenges that we have in both the clinical care and also in terms of research for this population. And so that would potentially then set up conversations and collaborations in the future for applications of AI for both clinical care and research. So my idea here is to really bring awareness to this population and also their challenges that they have, and collectively think through what applications could be there to kind of help with improving their care overall. So most of this I kind of think of as my dream rather than my experience, but one day hopefully it'll translate into action too. So children with medical complexity. So CMC is a short form for that. So if all children, a subgroup of children have special healthcare needs. So that would be children who have any number of chronic conditions, but the chronic condition then leads to need for specialist services or limitations in functions or need for prescription medications. So that is the subgroup of children called CSHCN, or children with special healthcare needs for short. And that is about 19% of all children. So if you think of children who have asthma, seizures, inflammatory bowel disease, all of those would be in the CSHCN group. And further subgroup of the CSHCN population are children who have more serious illnesses, and they are called children with medical complexity, or CMC. And that population accounts for 1% of all children. So it's a fairly small proportion. These children are also called medically fragile children, technology-dependent children, or children with complex chronic conditions, or chronic critical illness. So these are the various terms that have been used, but they all have certain things in common. These children have many different health conditions. Oftentimes, these are genetic conditions. It could be birth anomalies or mutations in their genes. But it could also be consequences of extreme prematurity. It could be consequences of events that take place surrounding the birth, or in later life, it could be from serious infectious diseases or trauma. So all of these could potentially lead to conditions that could then lead to medical complexity. So even though this population is composed of heterogeneous children with heterogeneous health conditions, they all have certain characteristics in common. The most important of that is usually involvement of multiple organ system. And oftentimes in our practice, we see most children have involvement of their brain. And once there is involvement of the brain, then the consequence of that is that it affects every other system. So they may have a gastroenterology issues, they may have problems with breathing, and so on and so forth. And so all of this means then that these children need care from multiple specialists for a long time, and also need care from many different services. That would be like physical therapy, occupational therapy, speech therapy, so on and so forth. And in our practice, if you think about a child who is healthy, they would need their pediatrician and a dentist. But a child with medical complexity, in our practice, we've seen that they often need 10 different specialists in addition to the primary care physician and the dentist involved in their care. So a huge network of providers involved in their care. So these children are also often dependent on technology. That's why they're sometimes called children with technology dependence. And so that means they need this for survival. And that means having a breathing tube, a tracheostomy tube, or having a feeding tube. It's called the gastrostomy tube. So those are all the common technologies that these children need. And so because of all of these health conditions and the technology that they use, they are often seen in the hospital repeatedly. They get admitted in the hospital a lot. And even when they are admitted, they stay in the hospital for a long period of time. So again, like if you think of a child who is developing, who has a healthy, they rarely are in the hospital. They are not admitted to the hospital for most of their childhood. But a child with medical complexity, not only are they in the hospital for a long time, they also get repeatedly readmitted after their initial hospitalizations. They also come to the emergency room often. So these children used to die during childhood many years ago, many decades ago when I started practicing. But now, because of real progress in technology, medical technology, and also other treatments, these children are surviving longer. So that's a great thing that we are seeing now, that these children are able to live into, some of these children are able to live into adulthood. So this graphic kind of shows the CMC population. So most children are healthy. Um, and then a subgroup of these children, the 19%, have special health care needs, so CSHCN, but a very small proportion have medically complex conditions, or they are CMC. But when you look at healthcare spending, it's the opposite. So most CMC account for 33% of healthcare spending for all children in the US. So that's a pretty significant number. And then also, if you look at hospital charges, CMC account for 50% of hospital charges of all children in the hospital. So again, even from a policy standpoint and a health system standpoint, this population is very important because of their very high health utilization. So in some ways, this population is not different from adults with multiple comorbidities. An adult, 70-year-old with COPD, heart failure, and maybe a stroke, all of those condition will have similar features as a child with medical complexity. The only difference is that um, there are some uniqueness to the CMC population. First, um, these conditions are rare to extremely rare. I know, Arizu, you have the Fragile X syndrome. It's a rare condition, right? And we see children who have extremely rare condition. And giving some of the examples of children in our undiagnosed disease program. So we have a program called the Declan Donahue Collaborative Care Program, where we try to bring together all specialists involved in a child's care to try to come up with a diagnosis. So these are some of the diagnoses that we have seen, or these are some of the conditions that we have seen in that particular group. And you can see there are many of these conditions that are, the frequency is less than 1 in 1 million. Um, so so it's almost impossible to know all the details about every single one of these conditions, and there isn't even information about many of this. So I just had a child I'm taking care of now with a very rare mutation. It's called UBA5 mutation, and there are only about 50 people in the world diagnosed with that particular mutation. So we are trying to try to come up with a plan, a treatment plan for that child. But if there is no literature other than a description of some of the phenotypes of that child, of that condition, how do we decide on what's the right treatment for that child? So that is one of the biggest challenges that we have, is that many of these conditions are so rare, ultra rare. The second part is that these conditions, many of them, many children have these complex conditions, but we don't even know what their diagnosis is. So again, in our Declan Donahue program, that's the DDCCP for short, we try to come up with a diagnosis, and we were able to reach a diagnosis in 70% of, this is a little like a data from a few years ago, 70% of children who were referred for coming up with a diagnosis. And so you can see, even we did maximal genetic testing, including whole exome sequencing, and nowadays even whole genome sequencing. And even after that, sometimes we don't have a diagnosis. We're able to exclude diagnosis or come up with diagnosis in some, but in a large number here, in 10 of the 32 for whom genome testing was done, testing was negative or inconclusive. So where do these children have all these symptoms, but we don't still have a diagnosis? That's why, Arizu, your talk was so intriguing to me, because you could find other people with the similar symptoms in, could have the same condition as Fragile X. So that's pretty impressive to hear. To hear that, and I just wondered if there is an application in this population as well. So I'll talk about it a little bit more later. The third problem we have is that we don't know what the illness trajectory is for many of these conditions, and so that makes it very difficult to prognosticate, especially life expectancy. So to give an example, we did a study based on our clinical experience. We had 17 children we prognosticated as dying imminently. And these are not children we say will die 1 year from now or 2 years from now. Now, we sent home 17 children who we thought were going to die in the next few days or so. But 8 children survived way longer than expected. And the median survival rate time was 1.5 years since the time of prognostication. And then 9 children survived beyond the observation period for a median survival time of 6 years. And I bet some of them are still surviving, even though the study was done in 2018 and the data were from 2016 or 2015. So you can see how so prognostication is very difficult in this population. And that has consequences for treatment. And like some of these children missed preventive treatment because they lived on, thinking that even if they were sent home on a different plan, but they continued to live on. So it's really important to know that the difficulty of prognostication and the consequence of that. And then the fourth part of this CMC population, the fourth difficulty is the unknown long-term outcomes, especially for those outcomes that are clinically meaningful. And so we do, I told you that many of the medical technology and treatments have actually had improved outcomes of survival, but survival and hospitalization alone may not be good outcome measures, especially if we think about family-centered outcomes. They are good, but families really need to know how does the treatment affect and the illness itself, what's the effect of that on the child's growth and their normal development, functional status. Those are things that are clinically meaningful, and we just don't have data about that. So I won't read this code. This is from a qualitative study we did about decision making about tracheostomy in children with medical complexity. And so we interviewed caregivers and asked them about their experience with the tracheostomy decision making process. So here is a parent who's reflecting on the process, the decision making discussion. And normally what happens is the providers get together with the parents and kind of discuss why, provide the rationale for why tracheostomy is advised. And so this parent recalled that decision-making conversation, and she said, I'm just going to read the last sentence that said, they basically told me that the child, would be a vegetable for the rest of her life, and she's far from it. So essentially, the clinicians were incorrect in their assessment of how the child would function in the future. And finally, I talked about it a little bit, unclear effects of treatment. So there are so many newer treatments that we are getting every day. And even with the established one, we don't know all the outcomes of the treatments that we use. So this again from the same study about tracheostomy decision making. And we asked them about why the family chose tracheostomy and what they are seeing, whether they have any regrets about that decision. And when we were talking about, when we asked about how they feel about their decision, this parent was really, they liked how the child was doing after the tracheostomy, and said that all of these benefits that they mentioned, the child is able to breathe better. That's not surprising. We would expect that. But the child was able to sleep better, was more alert, color improved, energy level improved, growing well, was gaining weight, hair was growing well, nail was growing well, and less making developmental progress, was calmer, more comfortable, and happier. None of this has ever been reported before. So you'll be surprised, like this is, so it's increasingly common procedure, but this is the first time somebody has reported these outcomes for tracheostomy for this population. This was not our goal. We didn't intend to write a paper about looking at the outcomes, but it came out in qualitative data. So there is no other survey asking about how children are doing or doing outcome studies following these children for, let's say, 5 years, 10 years, really looking at some of these outcomes. So it is pretty, so if you can think about it, like clinicians are making recommendations for tracheostomy based off really their own anecdotal experience, but really nothing to guide them in making decisions. So I'm going to pause here and see if people have any questions before I move on to the next piece.
I have a question.
Yes.
So for those who survived further than expected, have you looked at some of the features of those or characteristics of those survivors, like in terms of medication that they have, family status, those kind of variables? Like what is different in this population compared to those who didn't survive?
That's a great question. Yeah, I haven't. Might be it might be a project to kind of think about, right? So we don't know what it is. partly is just because we think that these conditions are uh, fatal, but it's not. So partly it's just incorrect prognostication, I would say, because there is nothing else to compare to. The only comparison could be made to historical cohorts, and even there may not be exactly the same type of diagnosis for some of these children. Whereas for some children, like for example, trisomy 13, trisomy 18, those are some conditions. Clearly, there has been a change in survival just because families are choosing um, life-sustaining treatments for those population. That one will clearly would be a predictor for survival. But for the population that we send, it's a mix of different conditions, but there is nothing we know, and I don't even know what else we would compare it to.
Okay. Thank you.
Yeah, so that's a good question. And again, there was I don't know if anybody saw, there was an article in the New York Times, maybe this past week or this week, I think, about uh, different pathways parents took the same condition, trisomy 13. It's a rare genetic disorder, um, but one family chose the child to have a tracheostomy, another one focused on comfort care, and the child died. So they had two different approaches, and so we see that in our setting too. And then again, even within a particular condition, everything feels like there is a spectrum, and it's not one specific set. So like there is a spectrum of illnesses that could potentially lead to higher or worse prognosis versus certain constellation leading to better prognosis, mostly clinical.
Very good. Thank you.
Yeah, so this project, this is the telehealth for CMC. This is the pilot study that uh, I mentioned about that got funding from a CTSI pilot grant and also supplemental funding from CARE. Um, so what we tried to do in this study was right after COVID, when we saw that access to specialty care was threatened pretty significantly because of cancellation or shutdown of clinics, we thought we should look into that more systematically. So so this also is interestingly came from a neurologist, Dr. Greffy, who reached out to me around the same time to kind of, she had the same observation about worries about how some children are not getting um, care from her specialty clinic, neurology clinic, uh, because of the shutdown. So what we did was we thought we would take this opportunity for using our EHR data to address our research question. And what we asked was, does telehealth provide more equitable access to healthcare services than in-person clinic visits for vulnerable children? So we had three aims. The first one was to evaluate the effects of telehealth visit and compare it to in-person visit for outpatient neurology access, um, and essentially looking at the number of clinic visits completed, canceled, and no-showed. The second aim was to look at outcomes of CMC, the hospitalization rates, hospital days, emergency room visits, and mortality rate. And the third one was the qualitative study. And here looking at the benefits and challenges of telehealth versus in-person visit for medically fragile children. So for aims 1 and 2, so for aims 1 and 2, what we looked at EHR data. So for aim 1, we had the database of children attending pediatric neurology outpatient clinic at Brenner. And for aim 2, we have a database of children referred to our complex care program, which is called the enhanced care program. So, and for aim 3 was a combination of these two aim 1 and 2 cohorts. And from there, we chose a sample of 23 caregivers of CMC. So for AIM-1, these were children who were scheduled for a pediatric neurology visit in the pre-pandemic period. And we included children who were younger than 18, lived in North Carolina, and had an appointment scheduled during the pandemic. And then there was an independent variable, was whether they were a telehealth user or a non-telehealth user. And then we had 2 time periods, in the pre-pandemic period and the pandemic period. Outcomes we looked at were visit completion, cancellation, and no-show rates. And we had age, race, ethnicity, health insurance, distance from the hospital, rural versus urban residents as covariates. So in the first paper from this, which we published in North Carolina Medical Journal, we have, here is the demographic characteristics. You can see here that children who have public insurance are more likely to be non-telehealth users, or less likely to use telehealth. And then children who are vulnerable, racial ethnic groups, like Black children and children of non-Hispanic, children of Hispanic ethnicity, are also less likely to be telehealth users. And interestingly, children who lived farther from, so distance from the hospital, so children who were non-telehealth users were also were lived closer to the hospital than those who were telehealth users. So in terms of appointment outcomes during the pandemic, and you can see the differences in completion rate, cancellation rate, and no-show rates, both in the comparing to the pre-pandemic time to the pandemic time. So there was a significant decline in completion rate during the pandemic, but it was much more pronounced for those who did not use telehealth. And the cancellation rate increased pretty significantly for both the telehealth user and the non-user, but it was much more markedly increased for the non-telehealth user. And the no-show rate, interestingly, children in the non-telehealth user had at the baseline missed more appointments, but also during the pandemic, there was an increase in missed appointments for the non-telehealth user. So which means that telehealth offered protection for appointment completion. So these are 2 multivariate models. The first one is canceled compared to completed appointments, and the second one is missed appointment to completed appointments. So as you can see, there are some variables that are significant. One is age. So older the age, or older children are more likely to complete appointments than, and also less likely to miss appointments than younger children. But again, like the pandemic was a pretty significant factor, and there were more cancellations and missed appointments because of pandemic adjusting for all other factors. But interestingly, also you see that Black children were more likely to miss appointments even after adjusting for the pandemic effect. And also children who had public insurance were also more likely to miss appointments. So we did a stratified analysis looking at the interaction of the pandemic period and the telehealth user versus non-user. And what you can see here is that even in the stratified analysis, in the pre-pandemic period, there was not a significant difference between the 2 groups, with the telehealth user and the non-user, in terms of either canceled appointment or the missed appointment. But what was significant was during the pandemic, there was a significant increase in both cancellation and missed appointments for children who were not telehealth users. So what we concluded was that the completion rate for pediatric neurology appointments reduced significantly during the pandemic, which is not surprising, and telehealth actually helped mitigate this problem. But what was interesting and explains the disparity here is that children of minority race and ethnicity are less likely to use telehealth, and this increases their risk for not accessing neurology services. So when we looked at children who are Black, who are more likely to have missed appointments, we thought, okay, so what if we then looked at phone users versus video users? Would there be a difference? So this is the second paper that we published in the Journal of Child Neurology, and we looked at the subgroup of children who had a telehealth visit, and uh, divided them into phone users only or video users, or used both phone or video. And so again, you can see here is that children who have public insurance and who are Black and who are of Hispanic ethnicity are more likely to use phone rather than video for their telehealth visit. And again, looking at the same two models that we saw before, cancellation compared to completed, and the other one was no-show, which is missed appointments versus completed. You can see that the audio phone visit had a protective effect in reducing cancellation. Both both the phone visit and the video visit did. Whereas for the no-show model, only the phone visit had a protective effect. Video visit was not. Again, one more thing I want to point out here is that Black children are more likely to use um, uh, to have missed appointments, even adjusting for other factors. So because of this, we wanted to look at a subgroup of children of Black race. And again, what we found here was that the cancellation, again, the same model, you can see the audio and video visit, the cancellation reduced in both of those. But for the missed appointment, for only the audio visit, missed appointments were reduced. Again, what this suggests to us is that a phone visit has a protective effect on avoiding missed appointments. So telephone visits improved access to outpatient pediatric neurology appointments, especially for Black children. So if we reverse policies to reimburse telephone visits, so this could deepen the socioeconomic divide for children's access to neurology services. So to give some context for this, during the pandemic, telehealth visit was reimbursed really well, but the insurance companies have kind of taken away that provision. And so that can have consequences for children, especially for some vulnerable groups like Black children. So I won't go into the details of this. This is the second aim of that project. We looked at CMC's outcomes based on telehealth. But here what we found was that there was a substantial reduction in hospitalization rates, hospital days, and ER visits between the pandemic during the pandemic period compared to the pre-pandemic period. But there was not a whole lot of difference based on the whether they used telehealth or not, but we still haven't completely analyzed this data. So third aim is the qualitative interview. We interviewed 23 caregivers in 2022 about their telehealth experience, and we selectively recruited based on our first and second aim. We selectively recruited groups that are more vulnerable to not receiving telehealth, and so we asked them asked them about their experiences and their perspective on telehealth. So so I'll just point out to a few things in this demographic information here. So you can see that the median number of visits per year were 8 visits. So that's if you think about a child who's healthy, they won't have 8 visits to the to specialists or physicians in a year. But then the range was 1 to 24. So some children are really in the hospital quite a bit. So this one, we use a validated telehealth usability questionnaire. And again, like I won't go into the details of these subscales, but overall, the overall score was very high, 6.3 out of a scale of 1 to 7. So that's a really good, that means people are comfortable using telehealth. So main themes from the qualitative data are telehealth offered a very good alternative to in-person visit during the pandemic. And this was mainly because it limited exposure to infections for these children. Again, these kids are very prone for severe illness, even from minor cold. Parents were so scared of bringing these kids to the hospital. So this telehealth helped prevent that infection exposure, and specifically about COVID. And it also helped avoid hospital rules and restrictions, mask use, number of people that can be with the child during the visit. All of those rules were hard for these families, and so that was avoided because of telehealth. And when children could not get care because the clinics were shut down or they had to stay at home if they had a minor illness, those then telehealth became a great option for them to get care. The second theme, this was very interesting to us, is that the benefits of telehealth were extended beyond the pandemic. So many families said how incredibly difficult it is to bring these children to clinic appointments. They said, like the child's weight and they're not being able to move and the need for carrying all this equipment and supplies made it a very, very difficult thing. So one of them called it a circus, another said it's a production. So it's really difficult. And then also coupled with the long drive, and many of them did not have predictable transportation, and parking and navigating the hospital was such a big challenge. And so also telehealth help was less disruptive to the child and to the family and less stressful for caregiver. And they thought that providers were better able to see the child in his or her own environment. And overall, caregivers thought that appointment cancellations were fewer if they had the option of telehealth. But there were some technological challenges. One was not having the tools for telehealth, especially not having the EHR portal. This was especially problematic for Spanish-speaking families. They were not able to understand the instructions or go through with using the video visits. Some of them said that care providers, specialists did not offer telehealth uniformly, so that was another problem. And some mentioned technical problems as well. So again, there were concerns with telehealth about a child not getting a thorough assessment or the doctor not being able to do a complete exam. And then also difficulty communicating with providers about their child, including because of technical challenges and not having that relationship with the provider. But overall, parents were very satisfied with telehealth as an option, and they said that they wanted telehealth to remain as an option even after the pandemic. And what was again interesting was that they said they wanted to be the ones to decide whether a visit could be in-person visit or a telehealth visit. So they wanted this shared decision making in which they could say, well, okay, for this visit, I want a telehealth. For this one, I want an in-person visit. So they wanted both, actually. So this then led to our PCORI Award, and we just started it in November. It's a 5-year project, and our question is, can enhanced primary care delivered via telehealth, we're calling that model E-Prime, whether E-Prime can provide superior care to CMC compared to a consultative complex care model, which is the current model of care that we have. So the E-Prime model has 3 components. One is the caregiver telehealth support. So we want to optimize how much support caregivers get in using telehealth. We also want to support primary care physicians so they can offer telehealth. And then those two won't be sufficient for medically complex populations, so they need more clinical support. So those 3 components together is called E-Prime. And then we're going to look at whether this model reduces healthcare utilization, hospital admissions, ER visits, days that children spend outside the home and in the hospital. and then also appointment cancellations or missed appointments. We're also going to look at caregiver stress and satisfaction. So I'm going to just pause here for a second to take any questions before I move to the final part. Okay. So here, this is where I'm going to just dream big and see what potential AI has for based on our both clinical knowledge and our research. So this is from our decision-making study. So this is we interviewed parents of children who had had a tracheostomy and asked them about their experiences. We interviewed 41 caregivers, and so tracheostomy is a life-sustaining treatment. Without that, children have a very high chance of death because the tracheostomy tube, which is placed on the throat, helps children breathe and get enough oxygen. And so it's a medical technology that determines survival. So, um, but having a tube in the throat has tremendous consequences for children and also their families because the care that these children need escalates pretty highly once you have a tracheostomy tube. So it's a really difficult decision for families to make. And what we found in our study is that there is wide variability in physicians' recommendations of tracheostomy. And when we did focus groups of physicians, they said that there is not enough medical literature on outcomes of whether tracheostomy is helpful or not for this population, and that makes it difficult for them to guide families one way or the other. So so to address this, um, we cannot do a randomized control trial of children assigning one group to tracheostomy and one group to usual care because then children in the usual care will die. So that's not an option. So we need to be able to look at do a comparative effectiveness trial or go back to our EHR and look at outcomes. But simply looking at children who have had tracheostomy is not sufficient. So simply looking at children who have not had tracheostomy is also not sufficient, right? Because you really need to know children who have had tracheostomy and compare it to those for whom tracheostomy was advised but not pursued. So that should be the comparison group. And this is where AI can be really helpful because we cannot do that with any other method. So maybe we should be able to go back and look at EHR, the clinical notes and meeting notes, all provider progress notes, and say, assemble a cohort of children who who have not had tracheostomy, even though it was recommended. So to to define that group, to identify that group of children, a specific group, there is no other way to do that other than as AI, using an AI application. So this is one project I had um, envisioned, and I think Arizu, we talked about it when you just joined. We submitted a letter of intent for CTSI pilot grant, and then that was accepted, but I didn't have the time to write the full application. But maybe next cycle we could do this. But I think there is a big value here, really understanding the outcomes of children who have had tracheostomy, which we can do from clinical data, right? So we have children in all through advocate of children who have had tracheostomy and they are followed in the tracheostomy clinic. That part is easy. We can assess their clinical outcomes. We can also do surveys of their parents, ask about their stress. But the part we don't know, and I would really love to think through more, is the group of children for whom tracheostomy was advised and was not pursued. Then what happens to those children? So the second idea that I have is about clinical summary. So as I said, these children, CMC, receive care from many specialists and many services. So there is lots and lots of data about their care. So a child without medical complexity, a child who's healthy, developing fine, may have one note per year from their pediatrician, whereas this child with medical complexity has thousands of clinical notes from many different specialists and services over a period of time. And so what we did was, it's very difficult for any one provider. If I'm going to go see a child with medical complexity, it's hard for me to assimilate all the data that's there to inform what's going on and what the plan of care of every other provider. So in a randomized control trial, we just finished this. We did one. What we did was we summarized. A nurse summarized all the clinical information for a child in the form of a clinical summary. We call it clinical summary. It's pretty comprehensive, and we shared that with primary care physicians and put that in the child's chart. So our goal was to share it with home health nurses and see whether it helps home health nurses. And the summary actually looks like something like this. So it has details of clinic visit, the plan from each one of the specialists, and what are the diagnoses, what are the medications, and what's the diet, what is the feeding, when is the next coming up appointment that happens. So a nurse from our complex care team creates this and then shares it with all the concerned parties and puts this in the chart. So what we found was that it's very popular among primary care physicians. They loved it. They just absolutely loved it. There's nothing else that I could have done that would have made primary care physicians that happy. They said this was really helpful, helped them manage the care of these children. And so we actually incorporated this as part of the E-Prime model in our PCORI award. But here is the problem. So it takes 4 to 5, 6 hours per summary. That's a minimum, because there is so much data. It takes for a nurse's time to create this summary. And it's my question has been then, is it possible for AI to generate a clinical summary? And if it did, how effective would that be compared to a nurse generated clinical summary? Because it's pretty remarkable. 4 to 6 hours of a nurse's time is just it's very expensive as well. And it's not scalable. So is it possible that AI can generate clinical summaries? And if it did, how comparable is it to a human generated clinical summary? So these are some other ideas that, based again on our clinical and research experience, we did a qualitative study about home health nursing. Many of these children, many of the CMC receive home health nursing support, but there are many, many problems with that, including shortage, home health nursing shortage, quality of nursing not being adequate, and then policy changes. So what this all leads to is that a very inefficient home health nurse assignment to a child's care. And so is it possible to match home health nurses to children based on certain characteristics? And would that take some of the middlemen in that process? Because there are schedulers who manually do this, and it's not a very efficient process. And so everybody is dissatisfied with that process. The parents are dissatisfied, nurses are dissatisfied, because manually somebody is trying to match a nurse to a child, and there are inefficiencies in the system and biases in the system. And can we remove some of those barriers if we used some sort of a technology to do the match? And then the next idea is, this builds on what you said, Arizu, is that with many of these ultra rare diseases, we are seeing children with certain constellation of symptoms. They have somewhat similar symptoms, but they don't fit into any one particular diagnosis. And sometimes the problem here is it's really difficult to tease out whether these conditions are real versus whether they are not, and it's directed by parents. There are some some situations where they have been referred to child protection team because of concern of medical child abuse, which is a thing. There is nothing real, but the parent is driving all of this. So is there a way to define these constellation of symptoms and see if there is a pattern there to delineate between to identify children who have true sorry children who have true diagnosis. So that's another thing. And then finally, we use many different medications and treatment for many different symptoms, and we don't know what the long-term effects of many of these treatments are. So again, that's another thing I think could be potential for further AI application. And then finally, this is of great interest to me, qualitative data. I've done many qualitative research projects now, 4 or 5. I have tons and tons of data. And qualitative data analysis is extremely time intensive. And I have even thought about, would Chat GPT be able to do a better job than I do, yeah, or equal to that in terms of identifying themes in qualitative data sets? And if so, maybe it is, but if that is done, that would again save tremendous amount of time and resources, and we would be able to quickly advance some of the research in this area as well. So that is all my ideas, and these are all the different funding sources in my collaborators, and I'm love to hear your thoughts and answer any questions.
Wonderful. It was a wonderful talk. We really appreciate it. And there are so many opportunities for AI to contribute to help in um, not solving, but improving some of those challenges or helping in some of these difficulties that physicians, pediatricians, parents, and nurses are facing. So if anybody has question, okay, any question? I'm going to have to ask a few questions if it's okay with everyone.
Yeah.
So my first question is about does the source of illness has an impact on the way that some of these decisions are being made by parents and caregiver? I'm assuming if the condition is known to them from during the pregnancy and by newborn screening or from before that it become the time to make the decision, it would be different from if the illness is caused by trauma or sudden event in their life. So I don't know if it's in the scope of your work, but I was just wondering how the readiness of the parents to make that decision is impacting.
Right. It definitely is one of the many factors. The decision-making process for a child who has had a healthy life and then had a trauma and is in the ICU and had severe brain injury and consequences of that is very different from that of a child who had a birth anomaly. And the reason is because there is the time period before that illness where the parents have seen the child to be functional and in a different place than whereas there's not that reference for a child who has a birth anomaly. So that is a factor, but how does that affect the decision making process? In which direction? The directionality is not very clear. So we don't know if that would make them more likely or less likely to uh, pursue life-sustaining treatment. I think a lot of main factor is child survival, especially because we are here in the South. That's a big factor. Many of the families mentioned the spiritual aspect of this as well. And one of them said, if I did not pursue tracheostomy for my child, that means I am taking my child's life, and God has given this tracheostomy, and I won't take that away from my child. They kind of, some of them attributed that not pursuing tracheostomy is equivalent to killing their child. So that was so they made that comparison. So some of this is religious, and spiritual belief is a big factor. So to your question, it is a factor when what type of diagnosis is there, and what type of what type of when the parents come into knowing about their child's illness in the child's life. And the same thing is also true for providers. And we have seen both in our clinical practice and also in the research is that providers, physicians have difficult time recommending life-sustaining treatment for a condition like trisomy 13, especially when they see that there are brain differences in the child. Whereas they are more likely, they say if a child doesn't have neurological impairment, they're more likely to recommend tracheostomy. So there is that element as well. They think that they consider the technology to be futile in those situations. Yeah.
And okay, I have another question, but I'm gonna give other people. Okay, I'm gonna ask my next question. So, in your work on the comparing people who were using video telehealth and phone telehealth and coming to the clinic, did you also look at some of the other familial factors like education of the caregiver, socioeconomic status of the family in general, those kind of variables? And I mean,
Yeah.
you had insurance in there,
Right.
so it's kind of a proxy to some of those.
Yeah.
And I saw that in your newer work, you are collecting some of
Yes.
those information about education and such. So
Yeah. With the pilot study, we couldn't because we used EHR data.
yeah,
Yeah, but that is a limitation of EHR data. But yeah, you're right. In the PCORI ward, we are collecting all of that information. Those would be very important. I agree, especially for transportation,
right.
in-person visits. Many of them actually really struggle because of gas prices. They are just not able to bring them to clinic visit. And so, yeah, those variables are very important in deciding whether it's in person or telehealth.
And I also appreciate your note about language difficulties, especially for Latinos and Hispanic population who weren't able to read the instruction,
Right.
and yeah,
Right.
that's also a very important factor. Um, I'm going to ask one more question, if it's okay.
Sure.
Um, so, okay. Um, So you also mentioned clustering of these undiagnosed patients and or patients who have unknown conditions. I think you know that I really find this idea interesting, and but one of the difficulties of doing that, especially using EHR, is the EHR data is really sparse. So, and you know, there are a lot of zeros, and
Right.
then a few people have some conditions. I believe it might be even more complicated with this
Okay.
rare condition. So, do you have any ideas about how we can combine some of those conditions to make them more clinically relevant? It's a general question,
Yeah.
actually, but yeah.
I think this is where the natural language processing might have a role, because with all these children in their progress notes, for example, there is a lot of like description about the actual symptoms those children are facing that's not necessarily captured by a diagnosis code. So is it possible to kind of map, unless I'm using key terms, so can we create a library of key terms that we would look for in set, like in, we start with a group and then we say these are the symptoms that we are looking for in progress notes and in lab results that could potentially this is the set that we are looking for that could constitute a particular condition, because clearly the diagnosis is often erroneous, like,
Right.
so we can't. So I think maybe using a combination of approaches to identify those sets, I would
Right.
think.
Okay, very interesting. And okay, I don't see any questions in the chat yet.
Okay.
So I'm going to ask another one, and then I'm going to let everyone go. So in addition to some of these factors that contribute to the outcome of the patients, there are, again, hidden familial factors. Like there are studies showing that if the emotional state of the family also has an impact on the child, right? These are data that is not being captured in the electronic health records. So, and being a caregiver, especially for a child who has severe illness, is not an easy
Right.
task. Is there a way to capture those? We have done a project in which we used a speech sample to capture level of criticism in the family, emotional involvement of the parents. But in your new project, is this an information that you're collecting from the patients or from the families?
We are not, but we can certainly kind of maybe touch base to see how we could use that. So with the PCORI project, what we are looking at, what's the stress level, those as outcome measures.
Right.
And we are not using any of the caregiver level measures as like a covariate or independent measure. But if that's something that's you think should be included, we can certainly. I would love to hear about your prior work on that area. But we are mainly looking at as outcomes like stress of satisfaction and that kind of thing.
Very interesting. Thank you so much. Thank you so much for giving this
Thank you.
wonderful talk. Thank you so much for answering all of my questions. I really appreciate it. And I hope everybody has a wonderful time and wonderful afternoon. Thank you.
Thank you, Ariza. Bye-bye.
Bye-bye. Bye.